Welcome to Dementia Forum X YouTube channel. Today we're going to talk to Bogdan Draganski, professor in clinical neurology. Hi.
Hi, Tobias. Thanks.
Hi, how are you today?
I'm good. Thank you.
Well, that's very nice to hear. So I have a few questions for you, which I will be very happy for you to answer and elaborate on. Let's begin with you. Talk a bit about yourself and what you're doing.
Well, as you mentioned in your introduction, I'm a clinical neuroscientist. That means I am a specialist in neurology, in adult neurology. And of course, as it always goes alongside our evolution, we have a sub-specialization. And one of my main points also in my clinical routine is dementia. And that means patients with memory complaints or memory symptoms that come here to the Lennart's Memory Center at the University Hospital in Lausanne are seen in this center, and I'm one of the clinicians responsible for this. Apart from this, of course, I have also other responsibilities. I'm also active in research. I direct brain imaging laboratory where also we are trying to answer questions about brain function and loss of function, particularly with a certain focus on aging and cognitive decline.
Right, and you're also a member of this organization called Brain Fit for Life. Could you tell me a little bit more about that and how you became involved in that organization?
Well, it's a typical grassroots movement. It's some like-minded souls that talk to each other and coming from different places, different cultures, different languages, different even daily routine. I think I was one of the few clinicians there. And the intention was to bring research in brain function and dysfunction for the purpose of understanding memory problems and dementias. And that was again the intention. How can we close the gap which is getting wider and wider between very sophisticated research and the daily routine of patients with their relatives? And this is what we came up with, this idea of a grassroots movement, not representing neither a lobby, a research organization, whatever. It's just an organization that has its roots here in Switzerland, from colleagues from different universities and also some partners from industry, where we're trying really to make the link between research and clinic to work for the benefit of the patients. That's the main point here.
Right, that's very interesting. But you as a professional has been focused on diagnosis and prognosis and treatment. Is that correct?
Yes, that's right. Correct.
So why do you think it's so important with an early diagnosis?
Well, I think the field has moved from this concept of early diagnosis to the concept of timely diagnosis. Particularly now in the times of pandemics, we see how, let's say, facts from the medical world become deviated through the different perspectives of politicians, epidemiologists, etc., etc. And here I think we're talking about our lives, our loved ones, our friends, that eventually will become also patients with memory problems, dementia, etc. in old age. And up to now, we have to confess we don't have a treatment. That means the very simple question, comes, well, if we don't have a treatment and we have a very early diagnosis, how are we going and whom are we going to transmit this information? I'm in my late 40s, and imagine you have the magic trick and you says, Bogdan, you're going to develop dementia in 10 years. How should I react? Will I just carry on with my work? And I hope that through my research and everyday work with patients, I will eventually also benefit by myself? Or do I have to drop it, take a little bit of money that I have and go to a distant country, enjoy life for a few years before something happens? This is, I think, the ethical question. Of course, we are getting closer to disease-modifying treatments. There is already one example on its way to ask for approval. And here we face other questions. But let's say, if we take the example of other neurodegenerative disorders, not necessarily linked at the first instance with dementia, like Parkinson's disease, we are saying that before a specialist sees the first symptoms of this disorder, almost 70% of the cells which are involved in producing this substance dopamine that Parkinson's patients lack are already gone. It means the brain has an enormous capacity to compensate certain deficits. We see it in everyday life, or even repair. That means eventually the process of degeneration, be it in dementias or, as I mentioned, in Parkinson's disease, is going decades beforehand. And therefore, if we want also to develop certain strategies for protection of these cells, we have to be as much as early sensitive to this pathological process. That means, in principle, I would say, that was a long answer to your question. Yes, we should be aiming at early stages of the disorder in order to prevent everything what comes next, or even push it a little bit further. If we cannot really cure the disease. But again, we have to put this in the context of an individual, his or her wishes, and his or her demand, right?
Yes. So basically, you're saying that there are two sides of it. There's the ethical argument that says that if you receive early diagnosis for a disease that you cannot treat, that might increase the anxiety and kind of disrupt the person's life. But on the other hand, it would also make it possible to intervene with maybe not treatments, but with other methods to stay off the disease or prolong the onset. So there's still a medical value in actually knowing as soon as possible.
Well, I wanted to set the scene just to be clear what is the situation now. Of course, there is enough evidence that actually individuals with a diagnosis of dementia are much less dangerous for themselves and for their environment as the ones that are not detected. That means it's not that we are closing our eyes and we're saying we cannot treat, we should not. No, exactly the opposite. I just wanted to put, let's say, this statement foremost, because I think when we're talking about a certain disease, it's not an abstract creature. It's indeed it's personal faith and suffering and it's a tragedy actually. Therefore, we have to be aware of this because otherwise scientists and clinicians are seen just as the robots that are getting people, let's say, people's blood and testing and so on. No, it's not like this. We're also human beings. We have also our feelings, but there are some ethical issues that have to be indeed considered. But of course, everybody is better off, patients, relatives, neighbors, etc., when the diagnosis is set. Because you can imagine if somebody has indeed already an advanced memory problem, just forgetting your oven on and so on can really cause a major damage, even death of people who are innocent. Therefore, again, there is enough evidence that there are major benefits for the individual himself or herself and the surroundings if the diagnosis is set. The question is, of course, in the different contexts, what can one do and what one should do.
Right, and that brings me to my next questions, actually. So now you're talking a little bit about how an early diagnosis could help the patients manage their lives better, and that it would also be better for the people around them. But getting an early diagnosis, so that's also changed the prognosis in any way of how fast the disease develops and so on.
Well, this precludes, I would say, this what we call disease-modifying drugs or interventions, right? That means you can change the fate of the disease. Because when we talk about neurodegenerative cause for dementias, we're talking about something that very creepily starts. No one can say it started on Friday, the 12th of May, 2003 at 2:00 in the afternoon. It's not a stroke. It's not a sudden event. It starts. It's very insidious begin, but that is steadily progressive until a certain limit of functional autonomy or, let's say, interaction with the others is evident, and then it turns to a medical problem. Disease modifying means this trajectory of steadily decline is shifted a little bit up to the moment when indeed we have the magic pill which can cure the disease. That means what we can eventually try is to change the slope, that it is not that steep, that patients who are, let's say, supposed to become completely dependent on help from the others, instead of turning at age 80, let's say this happens at age 85. And you can say, well, with aging, there are other problems, and maybe in the meantime, this particular person will also have, let's say, a cardiac problem and so on, which will eventually lead to the end of life before this horrible situation comes when you are completely dependent on help, and it turns really towards against also your own wishes, what to do with your life.
Yes, and could you talk a little bit more about the current situation then when it comes to these interventions, and maybe also a little bit about the diagnostic methods that are available today?
Yeah. Well, let's start indeed from the diagnostic part, and then we'll go towards possible interventions. And even before diagnostics, we can talk about prevention. There are very clear guidelines, even recently in the press, I mean, the scientific press, they were some recommendations about particular lifestyle guidelines, which are absolutely clear to all of us, particularly the cardiovascular risk factors. I'm talking about high cholesterol, diabetes, high blood pressure, and what we unfortunately so much like to add, that means smoking and alcohol consumption, physical activity, plus few others are among the factors, lifetime factors, that contribute also to dementia. And here, of course, we are called as individuals, but also the broader public health system to assist to people at risk that can minimize these risk factors. Because obviously, we do not know so much about particular populations at risk, besides some very clear genetic causes. But maybe you have heard or read somewhere about this apolipoprotein E, ApoE, a certain genetic, let's say, formation, where in the normal population there are different combinations, because we have always one part of genetic information from our fathers and another part from our mothers. And there, under certain constellation, this particular factor can be protective. Unfortunately, it's a very tiny percentage of the population that has the protective combination. And much larger is actually the part of the population that has the risk factor, which is estimated to be around 6 to 8 times higher if you have this particular combination to develop Alzheimer's disease. We're not going to screen everybody for this, but imagine for one or another reason you have this information. Well, then, instead of, let's say, seeing black and really a tunnel ahead of you, you see much more the light at the end of the tunnel. That means, okay, if I can do something good for my brain, that means do more sports, get rid of the cigarettes that I smoke, do not drink as much as alcohol I would like to, then we are already in this context that we're preventing something. Of course, there is much more to be said. Of course, there are certain environmental factors which are not that well studied, but can also contribute to dementia. Of course, there is also the notion of social adversity. There are big studies that are showing that this combination of socio-economic status plus other factors can represent also an independent factor for morbidity and mortality. That means they're making you sick, besides all the other factors that I was mentioning before. That means social adversity per se has also a certain tendency to contribute to disease and to death. We don't know how much this applies to dementia. Our lab, with some partners, are trying to understand this, but this is also something that we have to consider. Because if you look at the statistics around the world, it's very clear that in terms of incidence, that means the number of new cases per year, is almost flat, even getting lower in the so-called middle and high income countries, including Sweden, including Switzerland. But in the low income countries, the incidence is going high. That means there are more new cases per year. Then the other metric that epidemiologists use is prevalence. That means the number of people around, not the new cases. Of course, in our countries, because of the lifespan that is increasing, although there are no or not as much as new cases as in the low-income countries, the number of elderly people with dementia is increasing too. That means it's clearly a socioeconomic problem. But let's put this aside. So far, prevention is important. They're very clear. Nowadays, 12 factors considered as modifiable factors that we can prevent, and we should really focus on this. Now, your question was on diagnostics. I think there, at least in the field where I am, school medicine, the concept is evolving. And of course, we all move from what previously was called evidence-based medicine to the so-called personalized medicine. That means we are more and more considering individual factors, be it genetic, etc., etc. But in general terms, there are already specialty memory clinics, like it was 20 years ago in the field of cerebrovascular problems, when there were the so-called stroke centers that were established, and they proved to provide better care to patients. The same is also the case now with dementia. There are specialized clinics and centers, at least here in Europe, with exquisite knowledge on this topic. And the good point here is, which again is making this field so interesting, is the multidisciplinarity. There are 3 subspecialties that are relevant to dementias. That's neurology. Well, sorry, I'm a neurologist, that's why I put it up front, but of course they have all the same weights inside. Then we have the psychogeriatricians, that means psychiatrists that are taking care of elderly individuals, and the geriatricians, that means the specialists in the field of care for elderly people, because you know elderly people have many, let's say, domains where they react differently to medication, etc. And these 3 medical subspecialties are working together to get prevention, diagnosis, prognosis, and eventually therapy to individuals with memory problems. Now, when we're talking about dementia, and I would even use it in plural form, dementias, we're covering a very broad range of symptoms, first of all, and of clinical signs. And they can be seen as a broad range in terms of different complaints that do not even touch only memory, as we can imagine, autobiographic memory, what did I do 2 years ago on Christmas, etc. But it could be also the severity. Sometimes we talk about subjective cognitive complaints. I'm, as I said, at a certain age, I work very hard. At some time point, I feel I'm not as efficient as I was before. Well, this is causing me some discomfort. I talk to other people, they say they're fine, but I'm not fine. And at some time point, I forget some events. If I don't write something down, I cannot recall the names of some people that I know very well. And this is also a certain population that we see in these clinics. And of course, all these complaints have to be taken seriously, because I'm not talking about something that I imagine, because all of us can come in this situation. Here, of course, at least from my perspective, the neurologist, besides, of course, medical history and, of course, all the details about these complaints, I'll be looking also at some additional signs that may be very subtle, but can be brought together in the context of the complaints. I'm talking about certain neurological signs that can be seen either in Parkinson's disease or other disorders that can be part and parcel of a certain neurodegenerative problem with memory complaints. And here we are talking about different ages. It's not that in these memory centers we are seeing only elderly individuals. We have patients here at the age of 40, at the age of 50, at the age of 60, because unfortunately, at least some genetic forms, they start very early. Then in terms of diagnostics, we have a certain range of utilities. I think the very important one is our ear and our eyes. Listen to the patient. The patient tells you a lot of important details, and that's, let's say, what at least I'm brought up with, and I would say it's the most important part of it, really to listen to the patient. Then what I mentioned, we have our little tests, which are standardized tests, like the Montreal Cognitive Assessment, which is looking at different domains, not only memory. Then there are really a range of utilities where, like Sherlock Holmes, you will be adapting your tests to the challenges that you see in due course of discussing certain aspects with the patient or the relative who is there. Then we have on our side neuropsychologists, very clever and motivated people who are at the interface, I would say, between even, I would say, science and hardcore clinics that are even more knowledgeable into all these aspects of standardized and not standardized tests of certain cognitive abilities. And if we are not getting up to then the idea what is the primary problem, because neuropsychologists are very strong also to localize the problem, let's say a certain type of memory problem, and the location of this problem in the brain. If we have not achieved this up to then we have also a range of non-invasive imaging techniques. I'm talking about brain imaging techniques that are helping us then to clarify things further. First of all, this is magnetic resonance imaging, where we obtain high resolution, three-dimensional images of the brain, where we can see, was there an old stroke that affected certain areas of the brain, which were not evident at the time, but really can explain at least part of the memory or attentional issues. Are there any vascular changes, like very little sort of areas where the brain is not getting sufficient amount of oxygen, up to, let's say, a pattern which is telling us also which one of the different underlying potential causes it would be. Then if this is not sufficient, we have a different type of imaging, which is from the arsenal or armament of nuclear medicine, where very slight radioactive substances are used to tag, that means to mark certain molecules. For example, if we mark radioactively a glucose, sugar molecule, we know that all the cells, they love sugar. We can see with the technique which is able to capture this radioactivity, the distribution of areas which are active, that means the cells there are taking in this glucose and using it to function, and areas that are not using it. That means we're getting a map of the metabolism, that means of the activity of the brain cells. And of course, we have meanwhile sufficient knowledge to see, well, this card corresponds much more to Alzheimer's disease. This card, this map, sorry, corresponds to another type of neurodegenerative disease. Along the same line. There are also, with this technique, ways how you can tag these abnormal proteins, which are so prototypical, for example, for Alzheimer's disease, amyloid beta, or the protein tau. And you can see also with this same logic, tagging them with very likely radioactive substances, how they are distributed in the brain. And this topological or spatial information is sometimes enough already to clarify the diagnosis. This is, let's say, the non-invasive part. And we have a slightly invasive part, that means a prick here in the vein to get some blood. And then we are looking at some so-called biomarkers, that means components in the blood that can be also telling us something about the underlying cause. And if this is not very clear, then we do the same, but we are not putting the little needle in the vein, but we are making this little puncture at the lower back, where we're getting the so-called cerebrospinal fluid, a fluid that is produced in the cavities of the brain, because the brain is actually swimming in this fluid. That means the brain is interacting a lot with this fluid, and some abnormal proteins stored in the brain or secreted by the brain can be assessed directly with this. It's neither so painful nor dangerous. It's indeed like blood work, and it's quite informative, at least what concerns Alzheimer's disease, which is, of course, the most common form of dementia. Well, I took a lot of time answering your question, but I think it's important to be clear that indeed now, without being neither very on the expensive side nor very invasive, we're getting really beyond what previously was just the domain of post-mortem study of the brain, but we can get indeed in living individuals also information that is sufficiently reliable that we can establish a diagnosis which is biology informed. This is what is the novelty in the last, I would say, 5 years, that we're getting already the biological signature of the different diseases, because in the most of the cases we have also from the clinical picture an idea what could be the genetic problem, what could be then its protein products, and then as mentioned before, we can understand why the certain distribution of areas affected, which explain, of course, the clinical signs that we can observe.
Yes, I mean, all of that is extremely fascinating. But one side question I came up with when you were talking, which I think might interest many of the viewers, is what you said about prevention. Like, how big role does lifestyle actually play in comparison to, say, genetics or other factors?
Yeah, you know, I'm not going to be black and white. Unfortunately, people take it as a sign of lack of knowledge, or the scientists, they cannot make a clear case of what shall I do and what shall I not do. But as usual, as in medicine and in science, we're talking about gradients. We cannot say this is good and this is bad. And when we talk about prevention, the current recommendations, particularly on the basis of what I was explaining to you, that the only genetic risk factor, which let's say is common to all of you, this apolipoprotein E genetic configuration. There are two studies that rely on really large-scale data, because this is now the time when it's not only Facebook, Amazon, and so on are boasting with benefits and big data, but luckily also we clinical researchers can rely in the good sense of it on using data, of course, following all the recommendations of privacy protection, etc. And there are two recent studies from the last 2 years. The one is looking at the general population in the UK, the so-called UK Biobank initiative. And the other is a study from the Netherlands, looking at the so-called Rotterdam study. And both deliver completely opposite results. The one says, if I have this constellation which is more in favor of eventually developing Alzheimer's disease, if I cut down on alcohol, smoking, and so on, then the chance of getting dementia is getting lower. The other says, well, if you have this genetic signature, whatever you do in terms of prevention, this is not going to help. I mean, it's not about now getting the position in favor of the one or another. I think always the truth is in between. It's just a very complex topic that we cannot just say, okay, we're looking from this or from this angle. I think we have to take really the data and try critically to look what do we have now as an evidence and what not. I'll give you another example. This is the role of education. Again, big studies really looking at millions of individuals say education is eventually a protective factor against dementia. Well, others show that it's not the case. Indeed, the level of education is going to highly correlate or explain the level of cognitive performance at old age with all these tests that I was talking about. But at least a very recent meta-analysis, that means analyzing all the literature that was published up to now, did not show an effect of education on the rate of change of our performance in old age. And to be honest, there are enough studies around. Also, millions are being spent now for certain programs where we have to work on more education, because you see, this is protective then for the cognitive outcome in old age. Well, at least the evidence up to now is not so much in favor of this assumption. But of course, I mean, you can say, well, education, that's also very one-sided, because education, of course, unfortunately, even in our fields, in terms of mid and high-income countries, also is highly dependent, on the socioeconomic status of your parents. This will define eventually also your style of life and so on. That means suddenly you come up again in certain streams, if we're talking about lifetime risk factors, which are eventually going to explain your higher or lower risk for dementia, which does not have anything to do with your level of education. See, it's so difficult to really discern all these influences of this many factors in our life, which are the genetic factors, which is the interaction with the environment, plus everything what individuals do in terms of harming themselves. And therefore, I would say, of course, just the simple logic of really not harming our brains with what is known to be harmful, and then the rest we'll see. But I'm confident that now with the progress in data science, that means making sense of big chunks of data, that we're getting also closer and closer to some of this really well founded recommendations that we can transmit to our to our peers, to our patients, that they improve the quality of their lives and particularly their cognitive performance.
Right. So I can imagine that it's difficult in many cases to distinguish causal correlations and simple correlations when it comes to lifestyle choices and so on.
Yes.
But let's move on to the last question then, and that is actually about the future. So where do you think that we will be at when it comes to diagnosis and prognosis and also treatment in, say, a decade from now? Is the future looking bright, according to you?
Well, I'm hopeful for our generation also to see a major quantum leap in if not treating, then at least pushing the overt signs of dementia further down the line in terms of age. Well, there are certain ideas. First of all, I was mentioning already one molecule that showed this year certain effects on cognition by lowering one of these proteins, the amyloid protein in the brain. Up to now, the indication is that it helps in very early stages of Alzheimer's disease. That means this pertains to your initial question, how important is it to get an early diagnosis? Well, you see, at least for this molecule, it will be important, first of all, to detect this early stage, and second, to be sure we are talking about Alzheimer's disease and not another type of neurodegenerative disorder with cognitive decline. And there, I think I'm hopeful. You see now with the coronavirus how industry and science come together and provide a solution. And I think the next should be indeed cognitive decline in aging. Then we were talking about prevention. I think we will be getting smarter and smarter, and we see this is one of the explanations why mid and high income countries are getting their lines flat or even declining in terms of new cases. One of these explanations is indeed better care, better education, less cigarettes, less alcohol, less harming events for the brain. And then, of course, there are many other promising areas. One of them more, let's say, in the technological part of it, by using lots of data gathered by, let's say, playing a game or using certain devices that you're gathering information. I mean, think of just using your computer, the way how you move or you scroll your mouse to click a window or something. This is already this data can be sampled, can say something about how you are choosing, what kind of trajectory, how quick you are. This can be compared, if you want, to the data from millions, billions other users at your age, your sex. Then I think of a gaming strategy of an old colleague of mine from the UK who developed navigational game where you try to, I haven't played it, but I have read a lot about this. You try to navigate your ship through certain seas, and there is very interesting information coming there, because spatial navigation is also one of the early signs in dementia, because it affects part of the brain, the so-called hippocampus, which is also crucial for memory. That means, without opening far too much from our inner and private world, I think for certain purposes, these technological developments are really good because they are ecological. We are using certain devices, and if this information in proper hands can be used by research and medicine to understand what's going on, this is also something important. Well, and also when we talk about prevention, I mean, I come from part of this world where this game is not played at all, rugby. But maybe you read in the news this British rugby player from the past, Steve Thompson, a former World Cup champion who suffers from an early form of dementia. And we know that head trauma is one of the risk factors for dementia. It's very sad. I mean, just reading the title that he cannot remember that he won the World Cup. Somebody my age, I mean, this is really tragic for him, for the sport, and for all the fans, I guess. And these are, I think, the points where normally we accept all these things just coming through the news stream, etc. But now I think at least each one of us, every one of us, from his own perspective, will see this and will reflect on this, and we'll see how important this is actually to get more understanding. Is it really a coincidence in his case? Does he have a genetic form, and just the fact that he was playing rugby, well, has nothing to do with it? Or is it something that's causative, what you said also before? These are the questions that need to be answered, and we are trying also to answer with our initiative, Brain Fit for Life.
Yeah, super interesting to hear your answers to all of these questions. And I think that's all the questions I have. So I would just want to thank you for participating on this YouTube channel, which we have started at Dementia Forum X. And again, thank you for participating. And I hope that you will have a very good evening now. And perhaps we can talk to you again at some point in the future. Thank you very much.
Thank you, Tobias. It was a pleasure. Again, the future is bright. I think, let's hope soon will be treatment, soon will be more knowledge in the field, and there is hope. Clearly, there is hope. Thank you very much.
Well, I'm very happy to hear that, and I think everyone watching this is very happy to hear that too. Thank you.